A very good afternoon and welcome to everyone who is joining us today. It's my great pleasure to welcome you to the opening webinar of the webinar series of the Austrian Platform for Personalized Medicine. The Austrian Platform for Personalized Medicine is, as you may know, a platform funded by the Austrian Federal Ministry of Education, Science and Research, as well as the Medical University in Vienna, Graz, Innsbruck, and the Center of Molecular Medicine of the Austrian Academy of Science. And I'm very, very happy to open the series with a topic that is very close to my heart, one that concerns social and ethical issues of genomic research. And I'm very, very happy as well to welcome Dr. Richard Milne as our first inaugural speaker. Richard Milne is, without exaggeration, I can say he's one of the leading people worldwide in studying the social and ethical issues related to genomic technologies. He is affiliated to the Institute of Public Health at the University of Cambridge in the UK, and also part of the Society and Ethics Research Group at the Wellcome Genome Campus, also in Cambridge, UK. And Richard, among many other things, is playing a leading role in the Your DNA USA study, which is the world's largest empirical research project trying to understand and explore public views on how their genomic and medical information should be used. If you haven't heard of the study, if you haven't checked it out, if you haven't seen the publications that have come out already, please do so. And I believe Richard will have many examples and also links to where you can find further information. And with that, I would like to hand over to you, Richard. Thank you very much for having accepted our invitation.
Well, thank you very much, Barbara, for the invitation and for the kind introduction. It's a real privilege to be able to come and talk to you today. So yeah, I'm delighted to have the chance to share the work that we've been doing over the last couple of years in Cambridge. And just as an introduction, so I'm, as Barbara mentioned, I'm a social scientist. I'm a sociologist by background, based in the Society and Ethics Research Group at the Wellcome Genome Campus. And the Wellcome Genome Campus, what you most commonly associate it with often is the Sanger Institute, which is one of the leading centres in the public sector efforts to sequence the human genome. And it's primarily a centre for genomics and biodata research. We're a group of social scientists based embedded within that institute, and we do research around the social and ethical questions associated with genomes and biodata, with particular expertise around public perspectives, genetic counselling, and more recently questions around data and both genomic data and other forms of data, other forms of health data. And in this talk, what I'm going to talk about is the work that we've been doing, as I said, over the last couple of years around public perspectives on the donation and sharing of genomic and health information. And this is, it's a very pertinent topic for a platform on personalized medicine, not least because the entire the promise of personalized medicine, the promise of genomic medicine, is very heavily based on data. It's a data heavy promise. So it's this medical model involving the characterization of individuals' phenotypes, genotypes, based on data drawn from a range of sources. So the one that we're particularly interested in is genomic data, but it's also health records, and increasingly it's data drawn from what might be non-traditional data sources, wearables, other forms of lifestyle data, things that have traditionally been outside the healthcare sector. But in terms of genomics, there's the the hope is that by drawing data together from domains that were perhaps traditionally research, that might have been considered research, and domains that might traditionally have been considered healthcare, you establish this, what the UK government's genomic medicine strategy describes as a virtuous circle of health and genomic data feeding and accelerating research. And you get a very similar set of future applications described in the publication last month of the National Human Genome Research Institute in the States, Strategic Vision for Improving Human Health through Genomics. And they come up with this beautiful infinity loop diagram, whereby genomics research, the generation of genomic data and its application to healthcare systems, and the generation of healthcare data feed into one another in this kind of never-ending, self-perpetuating infinity loop. So this promise of data-based or data-driven personalized and genomic medicine requires at least two elements. So the first, which is perhaps the one that the Sanger Institute has been most focused on, I think, over the last couple of decades, is about producing data, and producing data at ever faster and ever greater scales. So this is the chart on the slide here, shows the total amount of DNA read by the Wellcome Sanger Institute, showing the speed of the time that it takes to produce 1 petabyte of data, and the kind of rapid contraction of this time over the last 20 years, down to 35 days to produce a petabyte of data, compared to 7,511 days to produce the first petabyte of data. But as diagrams like that, the infinity loop, show, it's not simply enough to be producing this genomic data. It's also necessary for it to be used, and for it to circulate and be shared and be analysed and applied. And so that for that reason, you have initiatives like the Global Alliance for Genomics and Health, who are heavily involved in setting standards and developing both scientific and technical, but also ethical and social and legal frameworks for enabling data sharing in the pursuit of realizing the benefits of genomics for human health. And more recently, I think we're within the context that leads to this being a webinar rather than an in-person seminar, the value of producing and sharing data between research contexts and clinical contexts has become integral to things like the COVID Genomics Consortium in the UK, the COVID-19 data portal, and there are a range of these initiatives that have been rapidly set up that build often on the strengths of what's been happening over the last decade or more in genomics, to establish systems and frameworks to share health data to support the response to coronavirus. But what's also happened as we've generated more health data, and as we've started to share data, is the emergence of concerns about who knows what and who's using what data for what purposes. So this the quote at the bottom, the article at the bottom of this slide, is taken from The Guardian, from the UK newspaper, from its coverage of the UK election last year, which talked about the use of patient data from UK GP surgeries being sold to US companies. And it was a story that tapped into a concern that's been present within UK discourse around health data, within European discourse around health data, and more widely as well, I think, around the need for data to be used in a responsible fashion, in a way that is acceptable to patients and members of the wider public, from whom ultimately data and samples come. They're the people who donate or make available their data and their samples. So one way in which this has been talked about is in terms of ensuring the social license for research. So making sure that data initiatives and the use of clinical and research data aligns with what we might consider reasonable public expectations, recognizing the fact that the development of genomic and personalized medicine relies on the collective willingness of people to allow data about them to be produced and shared. And this is increasingly recognized through data initiatives. And I think that the quote here from the NHGRI strategic vision paper is really encapsulates a lot of what's going on. Talks about ensuring the identification of key issues and values that influence people's choices about the provision of personal data for research. And that this is important not just in a national context or even the context of a single health system or a region, but it's also important internationally. So the effective delivery of personalized medicine and of genomic medicine that is able to benefit the greatest number of people relies on the availability of data that reflects the diversity of the human population and that includes that diversity. And this is something that hasn't necessarily been the case with the samples that we draw on for GWAS analyses, and that have traditionally been used to underpin the development of genomic medicine. So we require an expansion and extension of genomic data collection and genomic data sharing, but that has to be done in a way that ensures that it aligns with how people value their data, how people value their information, and how people expect that information to be used. So part of our work around this has been in trying to understand and explore some of these values and issues and expectations. So this is so the thing that I'm going to mainly talk about in the next 20 minutes or so is the Your DNA, Your Say study, which Barbara mentioned. And so this is a study that's been running for the last 3 or 4 years, and it's led by Anna Middleton, who's the head of the Society and Ethics Research Group at the Wellcome Genome Campus. But it also involves a large team of international collaborators and that have been an absolute, with whom it's an absolute joy to work. We have this really exciting group of people, which also I should mention includes Barbara, who's one of the key collaborators in the project. And the aim of Your DNA, Your Say, so Your DNA, Your Say is a social science study that aims to understand attitudes towards and familiarity with the collection and sharing of genomic and health data. And importantly, we really, one of the things we really want to do with this research as well is to bring these public views to inform the development of frameworks and policy at a national and international level through organisations like the GA4GH, and also to inform public debate and public discussion around genomic and health data. So Your DNA, Your Say is a quantitative study. It's a large, a global questionnaire-based study. So it asks about people's views on data, people's experiences of providing data, making that data about them to be available, making data about them available, people's concerns about what might happen to that data, how it might be used, people's so questions about who people trust to use their data and what kinds of protections they would expect to be associated with that, with the use of data. And it does this through, this is a subject that is often, as I'll come on to show, is often unfamiliar to people. And so the questionnaire is based around 9 films that are pitched at providing people with an explanation of what data sharing is and why you would do it and who might be interested in using it. So those videos are made with Charlie, the little boy, who provides information about this in a kind of a manner that's meant to be accessible and non-threatening. the widest possible public, and it's also accompanied with text about these issues. The study is at our last count, the study was running in 22 countries. Our collaborators have helped translate the study into 15 different languages, so of which you can see a couple here. And we have now around 37,000 responses. So when we closed data collection towards the end of last year from these 22 countries and started our analyses and meta-analyses, we had around 37,000 responses, and these are from public audiences that are recruited by 3 market research companies in these 22 countries to be as representative as we can get. We're continuing to expand the study into new countries. So particularly we have a study that's almost up and running in Ghana, because whilst we have this global scope, there are still areas of the globe where we don't yet have information from, and we're interested in expanding as far as we can in those contexts. And so what I'm going to cover is 3 sets of findings that are from the Your DNA, Your Say study. The first is around the question of how willing are people to make their genomic and health data, anonymous DNA and health data, available for use by others, for use by doctors or for use by researchers. And we ask people about anonymous. We do make it clear that what we are effectively talking about anonymous is probably what you would call de-identified, but in order to, as I mentioned, to create a survey and a set of questions that are accessible to the widest number of people, the term de-identified doesn't necessarily have much traction outside fairly specialist contexts. So I'm going to talk about the overall willingness to donate, and I'm then going to talk through 3 analyses of things that we've explored as predictors of the willingness to donate. So particularly around people's familiarity with genetics and genomics, how people see DNA and genetic information, whether they see it as something different from other types of health information or not. And then finally, the question of trust. And I'm going to go into a bit more detail as well on this question of trust, because trust often comes out as one of the things that we regard as most important in terms of ensuring the feasibility and the sustainability and this question of the social license in terms for the use of health data. So I'm going to talk about who's trusted and how trust varies across countries, and then finally draw on some of the work that we've currently got under review, which talks about how you might go about building trust, what types of things that our survey suggests are the most effective. So to start off with, this question of how willing are people to donate their anonymized DNA or health data. And as Barbara mentioned in her introduction, this is work that we've been publishing over the last year or more. And I put a couple of the papers on there. There's a full list of citations at the end of the talk. But one of the things that we're most interested in is how willing are people to donate their DNA or health data, and who's willing. And to explore this, we really just use 4 very kind of simple measures in terms of asking people about how willing they'd be to donate their DNA or health data for use by doctors, for use by non-profit researchers, for use by for-profit researchers, and then reflecting the fact that this data, in order to have its maximum value within these genomic medicine loops, requires use by more than one person. We combine those measures to explore how willing people are to have their data used by more than one person. And at the highest level, when you put all 37,000 responses into a single figure, and you look at the proportion of people who are willing as opposed to those people who are either unwilling or unsure about the use of their data, around half, just under half of people say that they would be willing to donate their DNA and health data. So this is a comparatively low number. It's kind of I think for us it was slightly surprisingly low, but it does vary significantly between countries. So if you look across the 22 countries of Your DNA USA, you find the highest willingness to donate in Argentina, China, and Mexico, and the lowest in Japan, Egypt, and Germany. And one of the things that this study does, which is, which to me is fascinating, is start to generate questions about, well, why? And often, I think, from within the context of a questionnaire, it can be difficult to, I think, particularly at a detailed national level, it can be difficult to explore why in each of these contexts we start to see this pattern. And this is where this kind of wider network of collaborators is really useful, because we have people who are familiar with the local context in each country. So we're starting to develop a series of analyses that allow us to explore each national context in more detail. What you also see, though, as well as the national variation, is a variation in terms of the recipient of data or the user of data. Who is it that people feel that who is it that people are being asked to donate to, and how does that vary? So overall, we find that participants are most likely to donate to doctors, and that they're least willing to donate to for-profit researchers. And again, this is something that's familiar from the literature, that we find that people are that when a lot of appeals, a lot of initiatives around genomic medicine, a lot of initiatives around biobanking, for example, have traditionally been based around mobilizing people's altruistic spirit, people's willingness to donate for the greater good, either as an appeal to altruism or an appeal to solidarity. Whereas when profit is involved, or there's kind of a private interest motivation, it does seem that people are less willing to donate for those uses. But again, that's the overall analysis. Once you look at a national level, you again see variation. And what's interesting is that you see countries where there are greater differences. So particularly if you look at the differences between profit and non-profit research, you see countries like Portugal, Germany, and Poland where there's a large difference between profit and non-profit research, willingness to donate for those users. And then you see other countries where there's less difference between profit and non-profit research uses. So particularly countries like here we've got India, Egypt, and Pakistan, as well as China and the United States, where the difference is significantly smaller. And again, I think this is something that we're exploring with our collaborators. But one possible speculative hypothesis is that this may reflect different relationships between the state and the private sector in terms of the delivery of healthcare, in terms of responsibility for research, and that might be slightly what we're picking up here in terms of how people see themselves, of what people are to whom people are routinely asked to donate. So moving on to that, to then looking at not just understanding the pattern of willingness to donate, but actually what is it that within our data that we can say influences people's willingness to donate data about them. So here we used a meta-analysis approach to examine the relationships between willingness to donate and a range of different predictors of that. So as I mentioned, so familiarity, how people see genetic data, and then this question of trust. And we controlled those analyses, we adjusted the analyses for socio-demographic variables like age, gender, levels of education, and so on. So the first one we explored is familiarity. Give it away. But and I think it's important, though, before I go on to talk about what we mean by what we found in terms of familiarity, to clarify what it is that we're meaning by familiarity. So importantly, what we're not meaning is that we are measuring in some ways people's knowledge of genetics, or people's knowledge of how DNA is, the structure of DNA, or how DNA is translated and becomes. We're asking people about how familiar they are, and this might be because they've come across it in a cultural context. They might have watched Jurassic Park, or they might have had encounters with genomics on the basis of their position in society. So they may be a patient with a genetic condition, or they may have a family history of genetic disease. So there are a variety of different ways in which people may be familiar with genomics, and some of that may include technical knowledge, but it's by no means reducible to it. That caveat aside, what we did find is that people are generally unfamiliar with DNA, genetics, or genomics. So 64% of people in our sample said that they were unfamiliar with DNA, genetics, or genomics, and that consistently across countries, more people are unfamiliar than are familiar. But people were most familiar in Italy, the USA, and Sweden, and least familiar in Brazil, Pakistan, and India. We then, once people said they were familiar, we then asked them how they were familiar with genetics. And here, if you look across the whole sample, and we can break this down by country as well, I haven't done here, but if you look across the whole sample, the majority of people who were familiar said that they were familiar because of an interest in ancestry or genealogy, followed by people who had either a genetic condition or some family history of disease, down through people who are customers of direct-to-consumer genetic testing, or people who'd taken part in biobanks or were students. So, and we found in the meta-analysis that familiarity is important in terms of understanding what shapes people's willingness to donate. So we found that familiarity with genetics, kind of stated familiarity, is associated with significantly greater odds of being willing to donate. And that when we broke that down into personal familiarity as well, so people who were in these groups of people with genetic conditions or family histories, or people who worked with patients or with families with a history of genetic disease, that was associated with even greater odds of being willingness to donate. And as you might expect, given the differences in familiarity and the differences in willingness to donate, the size of the effect was heterogeneous, but it was consistently in the same direction across all the countries in our samples. And so what does this mean for how we approach genomic medicine and its relationship with the public? So our view is that it's not necessarily about increasing knowledge, but it is about creating an awareness of genomics and health data, perhaps just as part of everyday social and cultural life. That this is something that an awareness of genomics to becoming normalized may increase people's comfort with engaging with genomic medicine. The second question we explored was around exceptionalism. So this has been so the term exceptionalism comes from debates around genomics and genomic medicine that have been going on for a long time. The question of whether genetic information is something different to other types of health data, because it's shared, because it's predictive. It may have some unique features which distinguish it from other types of health information, and that therefore might shape attitudes around it in ways that are different. So interestingly, when we look across the countries, the overall, it's the difference between in the total sample between those people who said that DNA information was the same and those people who said it was different is minimal. They're both coming out at around 50%, but there is again this substantial national variation. So in Belgium and Russia, for example, the DNA was predominantly seen as the same as other forms of health data. Whereas in Portugal, Italy, Mexico, Argentina, and China, it was seen as significantly different. And this is something that we're very interested in exploring in future work as well. In terms of its effect on willingness to donate, again, it's a heterogeneous picture, but seeing DNA as something different was never in our sample associated with decreased willingness, and it was often associated with an increase in willingness to donate. So the implications of this in terms of how we talk about DNA and genomics in public discussion is that singling it out as something special or different doesn't necessarily have any any negative impact on people's willingness to participate, and that it may have positive effects. And then finally, I want to come on to questions around trust. So we know from existing research that trust shapes attitudes towards health data, towards genomics, towards people's intention to participate in research. And we also know that there is a distinction between trust and between the trustworthiness of the bodies that are responsible for data, and that trust itself is something that has to be built. It involves a commitment to making oneself trustworthy. And this is something that's recognised in the UK's recent genomic medicine policy, which talks about the importance of building robust policies and processes, regulations and legal frameworks around data sharing that are put forward in that framework as being integral to ensuring trustworthiness and thereby maximising public trust in health data, in the use of health data and genomic data. So in our work, we look at three questions that I'm going to discuss. One is who is trusted, the effect of trust on the willingness to donate, and then this final question around how we might go about building trust. And this last question really is part of our kind of commitment within your DNA USA to trying to produce findings and orient our our analyses towards questions that are policy that might inform policy and public debate. So it may come as no surprise to many of you that we find the highest levels of trust in individuals' doctors, in people's own doctors, and that this level of trust in people's own doctors is way higher than people's levels of trust in any doctor in their country. So this is kind of, to some extent, a difference between an individual's own doctor and a health system or a healthcare provider or framework. And that actually, when you look at across the chart, the difference between any doctor and a non-profit researcher is often fairly minimal. But both of whom are, in general, much more trusted than company researchers. Again, we see smaller differences in some countries, so particularly in Egypt, India, Pakistan, and the USA. But again, as with and that reflects what we saw with willingness to donate. And as with the willingness to donate, however, the use of genomic information within a genomic medicine service requires the use of data by more than one actor. It's not enough for it to go to somebody's own doctor. It also needs to go to researchers and other doctors, and potentially to companies, or at least private sector partners in genomic medicine. And what we found when we looked at trusting more than one individual, we found that 60% of our sample did not trust more than one individual or organization with their DNA or health data. So the overall trust was low. And that, in fact, when you look across the countries at who trusts multiple organizations or individuals, in very few countries did more than half of people say that they trusted. So India, Pakistan, the USA, China, and interestingly also, at least for me, the UK. And we've also know from previous analyses, so in the English-speaking country, the predominantly English-speaking countries in the sample, the UK, USA, Australia, and Canada, we did an analysis last year which looked at identifying who trusts, and found that those people who are most likely to be trusted were most likely to be male, they were most likely to be under 50. And so there's a question about how trust is distributed both across countries and then within countries as well. Trust is strong. This trust in two or more actors as using data was strongly associated with the increased willingness to donate. And that holds both across the board, and it holds for each individual actor. So it's important to trust the person to whom data is being donated, or who's going to be responsible for using data. But given the importance of trust, the next question is, what can be done to build trust? What are the measures that you might think about implementing that are most likely to increase trust? And in this analysis, we draw on this list here of options that we gave to people about whether they would increase, which of these measures would you see as increasing your trust, as increasing trust. And rather than focusing on individual level analysis of willingness to donate, we treat countries as the unit of analysis and focus solely on those who said that they would potentially be willing to donate their DNA or health information. So among those people who say that they might think about it, what is it that would increase their trust? And we use that data to generate country level ranked lists of these different measures in terms of their, from the most to the least important. And we look at that a couple of ways. So one is to just look at the kind of mean aggregated responses from each country across the different options. So here you see that the question of who's going to benefit from data use comes out as the most important, down through to biographies of researchers at the bottom. And this kind of, yes, provision of transparent information about who's going to benefit from data access was chosen by over 50% of participants, with the exception of a couple of outliers, particularly China, where only 32% of people chose that as an option. Some choices had particularly variable responses. So particularly around sanctions for data use, where you had some significant, you had the greatest variation between India, where only 5% of people chose that, where up to 60% in Japan. And then questions about, you know, how important is it to have direct interaction with gatekeepers, with the people who are, the organizations who are using data. So where you have some countries where it came out very high and some countries where it came out, Australia, Russia, some countries where it came out very low. Using the national rankings as well, we also generated a consensus ranking. So by weighting the responses in the different countries. And again, this gave a kind of similar, the same ordering, particularly focusing on questions around, you know, the questions that might enable somebody to assess the value of data sharing. So transparent information about who's going to benefit, knowing who's using information, knowing how others are going to benefit, not just in terms of the value of the data, but also the value of the data for the researchers, for the doctors, for the companies who are using it. What are they going to get out of it? And then also questions that are often protected in ethics, in ethics regulation, but that may be difficult to realize often in genomic medicine. So like this ability to withdraw one's data. So so having generated this this consensus list, I just want to come back briefly to the fact to some of the variability that we show there, because I think that it's useful to draw out some of the things that across the sample come out as being potentially important in building trust around genomic data and around the collection and use of genomic data. But it's also important to recognize that there is variability in terms of how valuable these measures are seen across the countries in our sample. So this dendrogram shows the correlations between every pair of countries in our sample. One of the things we're trying to do here is to understand the potential transferability of debates and measures across countries, and to maybe pick out clusters and areas for focus in future research. So at the highest level of clustering, what's interesting is that you end up with two distinct clusters, one which pulls together Russia, India, and China, and one which pulls together the other 19 countries of the sample. At a more detailed, granular level, the clustering identifies some pairings which seem, or some groupings which seem ostensibly logical, based on assumptions about kind of cultural proximity. So, for example, between the UK, Australia, and Canada. This doesn't necessarily tell us that exactly the same things are going on in these countries, but what it does do is create some really interesting possibilities in terms of how we might approach future comparative work in order to understand this global setting for genomic and health data. So just to finish off, so in terms of concludings, the headline, I think probably the most important finding is that around or even slightly under half of people are willing to donate their DNA or health data, and that there are a range of things that are associated with greater willingness to make personal genomic and health data available, including trust, familiarity, and how we see genomic information. That I think it's difficult to overemphasize the importance about transparency about who will benefit from data use and who's using data, and the need to work to protect the ability of people to withdraw or opt out of data use. But with this important caveat that one of the things that our study definitely does is show the heterogeneity and diversity of global publics, and that we shouldn't assume the transferability of policy across domains. So as I said, this has been the result of the work and collaboration of a huge number of people, so thank you to everybody there, including Barbara and particularly Anna Middleton, who leads the study. And if you'd like any more information about the work, or you want copies of any of the papers, or just want to talk more about it, that's my contact details, and those are some of the recent papers that we've published. So thank you very much.
Thank you very much, Richard. We have one. I have a question as well, but we have one from our participants, and the person writes, "I'm curious about the familiarity factor, which I understand, as you said, Richard, is not a measurement of their knowledge of genomics or genetics. Still, were you able to ascertain at all how deep an understanding the participants had who were not represented in the research about what they believed they were familiar with?" Was the question clear?
Yeah, yes, it was. Thank you. Yeah, it's a good question. I think so. No, I think we've taken it as read that if somebody says they are familiar with genetics, that they are familiar, and that I think that is where it becomes. It's one of the reasons that we split out familiar in general versus personally familiar, where one's had some kind of direct engagement with, particularly in that context, genetic medicine services. So no, I think we have no way of assessing whether when somebody says they're familiar, they're a professor of genetics versus somebody who has seen it on TV. It's
I hope, well, if this has not fully answered your question, please just let us know. In the meantime, we have one question that congratulates you on a very nice lecture. Thank you. I got lots of ideas. And then the person asks, may I ask what you think distracts people from donation? I suppose it means puts them off wanting to donate. Do you have any examples?
So no, that's also a really good question. I think the kind of deterrence from donation. I think one of the I think this is a question of both trust and distrust. I think it is exceptionally important that you if people don't trust, they are less likely to donate. I think the legacy of projects that are explained or set out badly, I think, is probably significant as well. And I think one of the other things that we've been interested in exploring is this question of unwillingness to donate. I mean, I think that one issue that is important, and that, so if you take initiatives like All of Us in the States that have made a significant, or are making a significant effort to address, is the legacy of previous interactions between health services, medical research, and particular communities. So, for example, the African American community, or where there is a legacy of mistrust, or distrust, a reasonable legacy of distrust and abuses, which makes relationships more difficult. So.
Yes, and from the overview that you gave, and also from our own research as part of UDNA USA, I understand that the reasons are quite region and country and population specific as well, right?
Yeah. Yes, I think yeah, I think the work that you and Torsten wrote on around the German data, I think this is the importance of having these country-specific analyses and local kind of understanding the local context of what's going on in terms of genomics and DNA.
Mm-hmm. Our next question, Richard, is: do you see similar constellations of perceptions in the realm of non-genetic donations or data sharing outside of the genetic genomic realm? For example, the person mentions blood donations and lifestyle information, so data in a broader sense.
Yeah, I should imagine that, that you're far better placed to answer that question than me. But I think that there is, I mean, one of the questions that we've been exploring recently is around, so we have a project exploring public perceptions of data collection from wearable devices, smartphones, non-traditional health data for use as medical information, particularly among older adults. And I think that you do see similar patterns of the importance of trust, the kind of the suspicion about private sector involvement, but also at times a feeling that kind of a private sector efficacy as well, or efficiency, that things are that people. So we've so we recently did a series of qualitative interviews, particularly focused around the use of these devices for detecting cognitive decline, but also because the interviews took place through the middle of the pandemic, inevitably touching on all kinds of other digital health applications. And with this tension between, you know, that people would rather their data wasn't necessarily available to Google, Apple, but also a feeling that Google and Apple do things well in a way that, particularly in the UK, the digital health response, the contact tracing app debate, for example, didn't necessarily go that well. So I think that, yeah, the questions around trust and the to whom you're donating, I think is it does translate across domains.
This brings me to another question that is being posed, and colleagues, please accept my apologies for not reading your names. I'm not allowed to do that. And this is a question, Richard, that I actually get asked sometimes, and now I have the opportunity to learn from you how to answer that. So it is, of course, very difficult to separate between for-profit and non-profit research. So is that a methodological problem, and what can we learn from the data here when it is very often not so clear-cut what purposes are driven by a commercial interest and what research or data uses are driven by public benefit motivations, as they are often intertwined? So how do you deal with that?
So I think this is one of the real. So I completely agree. I think when you look at initiatives like Genomics England, or over the last few works, I've done a lot of work within Innovative Medicine Initiative programs, where they are inextricably public-private collaborations, and so to meaningfully separate them at that level becomes incredibly difficult. I think that in my experience of doing qualitative interviews and focus groups with members of various different publics, that there is still a public perception of difference. And I think that to some extent the difficulty is in matching those two pictures of, and I think this is where the complexity comes from. This is where you end up with the newspaper headline talking about selling UK GP data to American companies, is the fact that the role of private companies in the delivery of public health services is often not something that has necessarily been flagged up or isn't necessarily transparent. And I think one of the study that was very interesting in that sense was the Wellcome Trust did a study called One Way Mirror of public attitudes towards commercial use of health data. And the difference in that study between the quantitative and the qualitative data was striking in terms of the difference between asking people about profit, for-profit and non-profit, where one assumes when one answers the question that it's possible to draw the line, versus the ability to have the kind of longer term conversation about how you draw that line, and the fact that it's maybe not something that one that is as visible in practice as it is when we ask people about this. But I think to most people it is still a meaningful distinction, I think.
Yeah, and also becoming increasingly important in what research participants tell us they want to see in informed consent forms as well. So I'm moving to the next question. The person says, also very interesting talk, thank you. I'm surprised by the 50% willingness to donate. Without having concrete numbers, I would assume that we would see a higher share once patients are in a university or hospital.
Yes, I think I probably, yeah, I think I would agree. I think once people are, I mean, I think that's once we know the people who are personally familiar are, so the people who are among them are the people who have had a personal encounter with the health service or research, and that the willingness to donate is higher. I think what's interesting, I think, is as genomic medicine initiatives attempt to recruit ever larger samples into research studies as well as the health service, I think it'll be interesting to see whether there are points at which people start to run up against the limits of who's willing to participate. So whilst it may be possible to get 500,000 people for a biobank, is it possible to get 5 million people? Is it possible to get within a kind of UK context? Are there? And what does that population look like?
Our next colleague is asking whether in your research data you have seen any patterns regarding urban and rural divides. So do urban and rural populations overall have a different attitudes towards donating DNA?
That's a that's a lovely question. I think by background, I have a kind of background in geography, and I think I kind of, it's a question I'm very, very interested in. Our we haven't looked at that yet, so we don't have granular enough data to be able to know exactly whether somebody's urban or rural, and we didn't ask them that. We do in so no, I think it would be a really great. I think there's one of the things that's been really interesting is, so it's to try and understand in more detail, because one of the things that might be interesting in an urban rural setting is people's relationship with their doctor or their local doctor as well. I think that you might expect in a rural setting that there is traditionally has been a stronger relationship between local medical services and that community. And so I think there's a lot of interesting things that could come out of that analysis. Unfortunately, we can't do it. So it's
yeah, and it might be worth mentioning here that a study led by Susan Kelly, a British study with British participants has, as you know, of course, Richard, but it has shown that people's consent preferences depend very much on whether they trust and know the person who's doing the research. So we have strong indications, I think, that people's relationships to their research nurse, to their healthcare provider, to their doctors, as you were saying, Richard, does have an influence on their willingness to participate. And I think this is an area that we still need to explore much more systematically. Would you see it this way as well?
Definitely. I think, I mean, one of the things, so we've just had an MPhil student here at Cambridge who's been doing some work on comparing questions around trust in the UK and Canada data. You're saying she's just writing that up at the moment. But one of the things that's interesting from that is the ability, is the extent to which the health system as a whole, or the question of any doctor in my country, can act as a proxy for my own doctor, and that between the UK and Canada samples, which are otherwise quite similar, they're both quite, their levels of trust across the board are quite similar. But in the UK sample, the ability of the health system to stand in for the doctor seems to be greater than it is in the Canadian system. And I mean, yeah, it's early days, but I mean, you can hypothesize that we have this kind of national mythology in the UK around the NHS and its creation and its centrality as to British society, and that potential valuing of the system decreases the reliance on an individual as opposed to the system as a whole. I mean, there are lots of very interesting questions about how trust works as a concept and what we mean by trust, and so yeah, I think these are kind of really interesting questions that lie underneath this that would be really useful to pick out more. And I think as a whole, the study has just generated this huge number of really interesting questions that, yeah, you can just keep going with. So.
Yeah. So we have time for one final question if anyone has one. I don't see any more in the question box, so I will maybe briefly ask another question that I'm thinking about at the moment and don't have a good answer to. So based on your research also outside of the UDNA USA study, Richard, do you think that the current COVID crisis in the UK has had an impact on people's attitudes to share personal health-related data? I mean, I know it's a speculative question, yeah. But well, so what is your sense?
It is one of the things. So we've done. So it's one of the things we've been exploring a bit in these qualitative interviews, and I think again, I mean, we're focusing particularly on older adults. I don't know. So I think there are two things. One is that there is a sense of sharing in an emergency and the need for things to happen, and the kind of willingness that comes associated with that it's an emergency situation, and if it helps, it helps kind of view, when it's something that definitely comes out among the people that we've been interviewing. I think the question then is definitely in the UK, the systems and structures that are being put in place to enable sharing in the pandemic at a kind of policy regulatory level are not necessarily things that go away. So there is a question about what we build in the context of an emergency that we might not otherwise have built, and then at what point do we turn around and look at that and say, is this what we would have wanted 5 years down the line, and is this where we wanted to get to?
Yeah, I think this is a very, very good point, and I think that we should also explore this in Austria. Actually, we have surveys running that survey the Austrian population. Anyhow, there's a lot of food for thought. We are at the end of our time. Thank you very, very much, Richard. I think you have, in the best possible ways, given us a lot of questions. And also, of course, answers, but many more questions also for further research. And it was an honor and pleasure to open our webinar series with you. And
thank you so much.
Be well, and hopefully we will be able to invite you to Austria at some point in the future. Thank you, and thank you everyone who has participated today. And the recording of the webinar will be made available, of course, through the usual routes. If you are not a member of the Austrian platform of personalized medicine, and if you're interested in what the platform is doing, please have a look at our website and get in touch with us. And on behalf of my colleagues at the platform, thank you again, Richard. Thanks to everyone, and stay healthy and well, and have a good evening. Bye-bye.
Thank you.